Good afternoon, everyone. Hypertension is one of the top cause of human deaths, and some of the literatures they have reported it as a number two killer, considering its direct and indirect complications and impact. Today, 1 out of 3 adults worldwide are suffering from high blood pressure, and the population from 2 out of 3 developing countries is victim of this issue. Talking about Africa, World Health Organization has estimated that the number of people suffering from hypertension they are the highest in Africa, which is about 46% as compared to 35% elsewhere in the world. And the most unfortunate part is that around half of them they are not aware of that they are suffering from hypertension. So it becomes very important that the timely diagnosis, preferably at early stage of this disorder. And in this webinar, Professor Mbakwem is going to focus on these particular issues and the importance of early detection, care, and control of hypertension by keeping community at the core. Myself, Dr. Rahul Mandlik from Shalina Healthcare, welcome you all to this webinar. Talking about Shalina Healthcare, we are present in Sub-Saharan Africa from last 35 years, and over this time period, it has been our mission that to make quality medicinal products and to make them available at affordable prices across the region. Today, we are one of the largest pharmaceutical companies in the region, and we achieve this by manufacturing our products at WHO approved facilities. We strongly believe in delivering the best care to our patients, and to achieve this, we partner with several professional bodies and associations to roll out many programs which are patient centered as well as healthcare camps. We are also very aggressively involved in, and we are with full dedication focusing on creating multiple platforms to provide learning opportunities to our healthcare professionals under the banner of Shalina Professional Engagement and Education, that is SPEED program. Under this, we conduct many educational programs through online as well as offline channels, by our global as well as local webinars, as well as some therapy-driven sessions at Shalina Learning Centers, which is present across many countries in Africa, and through CME meetings. With this, let me welcome our speaker, Professor Mbakwem. Ma'am is a professor of medicine at University of Lagos, and she is a consultant cardiologist at Lagos University Teaching Hospital. Her specialties are systemic and pulmonary hypertension, acute and chronic heart failure. Madam is immediate past president of the Nigerian Cardiac Society, a treasurer of the Pan-African Society of Cardiology, a member of the Nigerian Hypertension Society Guidelines Writing Committee, and a member of European Society of Cardiology Working Group on Peripartum Cardiomyopathy. She has been honored with fellowships from American College of Cardiology, ESC, as well as NCS. And Madam has been invited as a guest lecturer at Kenyan Cardiac Society meeting in 2017, and in preceding year as a ESC faculty at Saudi Heart Association meeting. Ma'am is part of many reputed international landmark clinical trials, and she has got more than 70 publications. She has presented many papers and has been a chairman at many national and international meetings. So, while attending this webinar, please feel free to post all your queries. And once presentation is over, we'll take up these questions during Q&A session. Over to you, ma'am.
Good afternoon, everyone. Is my screen visible?
Yeah, it is visible.
Okay. Thank you, and I'd like to welcome everyone to this meeting, this seminar organized by Shalina Healthcare. I'd like to say, thank you to them for inviting me to speak. What we'll be discussing today is early detection, care, and control of hypertension, but we're zeroing down to a community-based approach. So these are my disclosures. Of course, this webinar is being sponsored by Shalina Healthcare, but I have speaking engagements from Merck, Novartis, Boehringer, and advisory board for Astra, Novartis, and Merck. So what I would like to do in the next 45 minutes, 50 minutes, a bit of an introduction, then look at definitions. Yes, we're all talking about hypertension, just to make sure we're all on the same page. Then look, what are the guidelines telling us, what are they recommending as per diagnosis, evaluation, management, how do we aim to achieve control? And then what role has a community, got to play in this early detection and care and control of those patients who have hypertension? And then we'll look at evidence. I mean, is there evidence? Because we can all talk about excuse me, we can all spend time talking about community participation. On this day of evidence-based medicine, do we have evidence that that actually works? And then we'll conclude. So we all know that hypertension is an important public health challenge, worldwide, and that it's growing by the day. In 2000, it was said that about a quarter of the global population, that's about 26 million, had hypertension. And the projection is that by 2025, there'll be a 60% increase, taking out to almost 1.8 billion people, living with hypertension. But I think, that's not, if we haven't surpassed the prediction by now, the way things are going. Like Dr. Raul had said earlier on, we have the highest prevalence in Africa. If you look at the other region, this is a 2015 slide, it's a bit dated. While the prevalence is going down in most of the other high income regions, okay, Africa seems to be on the uptick curve. So, and I say that with all humility. This is a recent paper published last year. We're reporting on the data from a nationwide survey in Nigeria looking at prevalence, awareness, treatment, and control of hypertension. These are published in Global Health. And what they found was that the overall age-adjusted age-standardized prevalence of hypertension was 38.1%. And prevalence rate did not differ significantly according to area of residence, which is, very worrisome, because before we used to have all that dichotomy, whether you're a rural dweller or you live in the cities, the urban dwellers tended to have a higher prevalence of hypertension. But we seem to have eroded that gap. While it was 39.2% in the urban areas, it was 37.5% in the rural areas, and there was no significant, difference. So it doesn't really matter where you live, whether you live in the village or you live in the cities, we seem to be narrowing, that gap. So where are we, spending our Saturday afternoon, talking about hypertension? You and I know that hypertension remains the most powerful risk factor for cardiovascular morbidity and mortality. In 2005, this paper from 2005, the mortality of about 16 million for CVD, hypertension contributed half of it. And then when you look at half, the burden of disease, of CVD, hypertension plays a central role. So I believe that if we can get a hang on, hypertension control, then we can control, this galloping increase in cardiovascular disease in the region. We also know that the risk of CV mortality doubles with each 20 millimeters systolic and 10 millimeters diastolic increase. This was shown elegantly, in this meta-analysis of 61 prospective observational studies, looking at over 1 million adults aged about 40, to 69. And what you find is that as the, sorry, let me find my pointer. Okay, so as your blood pressure goes up, the risk doubles. So from 115 over 75 to 135/85, that's 20 millimeters systolic and 10 millimeters diastolic. You double your risk, and it's a continuous straight line curve, as it were. So if we can get blood pressure controlled, if we get the blood pressure at a reasonable level, then we can actually save a lot of patients the burden of cardiovascular disease, that is plaguing the continent, especially sub-Saharan Africa. So what exactly is hypertension? I just put this so that we're all on the same page, and just to show you that hypertension, it's not it's not cut in black and white. There are different shades of gray. Okay, WHO ISH will say generally that it's persistent elevation in systolic and diastolic blood pressure above what is accepted for the patient's age or sex. But we know that hypertension goes beyond the numbers. I like this definition put forward by the late Professor Jeffrey Rose, and it's over 40 years ago. We didn't take him seriously. Nobody adjusted the guidelines based on his, the argument he put forward. For him, hypertension is that blood pressure level at which investigations and treatment will do you more good than harm. And he's been borne out. His argument has been borne out over the years. We know that the target has been shifting. About 2 decades ago, we were doing 160/95, then we came to 140/90. ACC has even pushed it down to 130/80. So it's a moving target, and for obvious reasons, because hypertension, if I take the blood pressure of a normal population, it's a bell curve distribution that you would have. And then you and I will come with our science, with our statistics, and say, okay, the mean or the median or the mean plus 2 standard deviation, that is the cutoff. So it keeps shifting. And we know that the numbers don't answer all the questions. And in the same line, this group from America, the Hypertension Working Group, proposed this definition in 2005. To them, hypertension is a progressive cardiovascular syndrome associated with target organ damage, and that early markers are often seen before the high blood pressure values are observed. So by the time the patient is showing up in clinic with elevated blood pressure, things would have gone wrong, underneath. And they opine that hypertension cannot be classified solely by discrete blood pressure thresholds, which is what Professor Jeffrey Rose had said earlier on. And progression is strongly associated with functional and structural CV abnormalities, organ damage, especially the heart, the brain, the kidney, the vasculature, and it can lead to premature morbidity and mortality. And so this fits nicely into the concept of the CV continuum. So that it doesn't matter how you get into the continuum, whether you go via hypertension, you come via diabetes mellitus, dyslipidemia, and smoking. Everybody fits into the CV continuum. And we can't even look at them in isolation, because that hypertensive patient may also have dyslipidemia, may have diabetes, and we know that most of them congregate, and these risk factors tend to congregate, and they may also be smoking. And then once you enter the continuum, you can enter via oxidative and mechanical stress or inflammation, and then the journey starts. The early tissue dysfunction, atherothrombosis, and LVH progression to CVD, tissue injury. I know, and not everybody traverses the whole continuum. Some people drop off, along the way. Like when you have tissue injury, you have MIs and strokes. Not everybody will survive those acute events. But of course, once those things have happened, then the body tries to remodel the organs that have been damaged, and then we have target organ damage, and we have end organ dysfunction, and then the exit, either via chronic heart failure or end-stage renal disease, and the ultimate, exit point is death, which is where we don't want our patients to get to. Okay, so how do we classify hypertension? Like I said, many guidelines in the past decade, some controversial, and this has shown us that our targets are really moving, targets. Different cutoff points. We were doing 140/90. Everybody was very comfortable with it. Then JNC 8 came and kind of troubled the waters. And after that, ACC came, pushed the number, the cutoff point much lower because of results from the sprint trial, and then ESC and ISH. So in the last 5-10 years, there's so many guidelines, sometimes a bit confusing. But however, treatment targets are getting streamlined. So it doesn't matter what you diagnose, it doesn't matter what level you have taken, but everybody seems to be agreeing at where should we push these patients to once we have decided that they have hypertension. So I'll just give you a few, the next few slides on what each of the guidelines, what they're saying. So for ACC, AHA classification, so you just have normal, elevated, and the hypertension. So normal, less than, we want everybody to be less than 120 millimeters systolic and 80 millimeters diastolic. And once you're above that, 120 to 129, we're talking about elevated blood pressure. And the ACC says 130 to 139 systolic, 80 to 89. Your stage 1 hypertension, stage 2 is more than 140/90 and greater than 90. There's been a lot of arguments on both sides of the divide, over this new classification and all that. But whichever way you want to look at it, I mean, so I find it quite useful because not necessarily that at 130, 139, I'm going to start you on medication. But then I can, insist on you doing all the, lifestyle modifications, losing weight, reducing the salts, exercising, a lot more vegetables and all that. But, this has a lot of implications both to the healthcare providers, the insurance companies and all that. So there are a lot of, arguments going back and forth. The ESC guideline, which came out in 2018, maintained their old classification, optimal 120, less than 120/80. Then you have the normal, the high normal. So the grade 1 hypertension in the ACC is actually high normal for ESC, and they have grade 1, grade 2, grade 3 hypertension, and then the isolated systolic hypertension. And then the ISA 2020 guidelines, which came out last year, also streamline their definition. So less than 130 systolic and less than 85 diastolic is a normal. 130 to 139, so everybody high normal for ESC and for ISH the same. And they only have grade 1 hypertension and then grade 2, grade 1, 140 to 159, and 90 to 99 diastolic, and grade 2, 160, greater than 160 systolic and greater than 100 millimeters mercury diastolic. Okay, so with all those, fluxes at which way you diagnose the hypertension, like I said earlier on, that there's a bit of streamlining as to targets. So if you look at the, this row of uncomplicated hypertension, it was JNC that started all the troubles in the, in the guidelines. Okay, so now, so they said less than 140/90. NICE guidelines still insist on 140, less than 140/90, but ACC says less than 130/80, ESC less than 130/80, ISH, less than 130/80, preferred, optimal. But I mean, if not, at least try and push the patient to below 140/90. And then for the complicated cases, also a bit streamlined, less than 130/80. So if you have that figure 130/80 in your mind, you can't be too far, from the correct thing. Whether you have diabetes mellitus associated, you have CKD with proteinuria, you have other risk factors like MI, stroke, and then the elderly. This caused a lot of furrow in the, when the JNC8 came out, because the definition of elderly was put at more than 60, and then they wanted us to do just less than 150/90. And then some people, I know that the group in the guideline committee wrote a minority report, that didn't agree with all this. And now we're pushing to 130/80. I mean, I can change the, so now it's more individualized. It's not just the age. Okay, if you have a frail patient, then I probably don't want to push him so low. But some 80 years are stronger than some 60-year-olds. So we can't just use age as a number, to decide where to push the target for each patient. So where do we start? Proper evaluation is critical. Remember, we're talking about care, we're talking about control, we're talking about early management. Okay, so we can't properly manage these patients except we evaluate them critically and carefully. And this is where there's a bit of a dichotomy, because for some of the other healthcare providers or some of our colleagues, I mean, it's blood pressure, but it's a lot about blood pressure. It's not just the numbers, but I mean, one of the things this seminars, was trying to do is get all of us on the same board so that we're speaking the same language to the patient and the patient doesn't get confused. Because sometimes, I have a patient, blood pressure gets to 120, it's somebody outside, my practice, I'll tell them, oh, your blood pressure is normal now, you can stop treatment. Oh, it's getting too low, I don't want it to become hypotensive. But how? Patient doesn't have any symptoms, patient is doing well. And that is what they want to hear. Once they hear, oh, you can stop the medicines now, and they stop. And the annoying thing is that when the blood pressure goes up again, it's not going to give you some notice that I'm going up. And what usually happens is that we'll now find the patient either in the ER, we'll find the patient in the ER either with a stroke or with heart failure or other things that you and I don't want to deal with. Okay, so proper evaluation, because we know that hypertension is majorly asymptomatic. Most of the patients don't have symptoms. By the time they develop symptoms, something else is going wrong. They would have developed hypertension-mediated organ damage. So I don't want my patients to have symptoms. If they're waiting for symptoms, to happen, then it's a problem. And this is also, this also goes into why we're having such poor control, because there's really no incentive to take medication. The diabetic who is having polyuria, polydipsia, and is losing weight and all that, takes his OHAs or, and then finds that he's a lot better. He's not waking up so many times in the night to wee. So there's an incentive, but the hypertensive doesn't have any symptoms. Okay, and I'm asking him to pop pills every morning to control one imaginary number that he's not seeing, that it doesn't mean anything to him. And then my medications may actually give him side effects he didn't have. So the most logical thing would be to throw away the cause of your problem, and that would be our prescriptions, down the drain. And also remember that hypertension hardly travels alone. There's love in share. Love is in sharing. So hypertension is going, it drags along dyslipidemia, it drags along diabetes or impaired fasting glucose. Some obesity is coming with it, all sorts of things that will compound the whole picture. So we really need to evaluate these patients properly. And then, only then can we determine, the best management route, to follow for this particular patient. Remember that every human being comes with their own baggage, with their own story, and we try to individualize therapy to fit their own circumstances. So why are we evaluating them? You need to confirm the diagnosis, because that the blood pressure today is high does not necessarily translate into hypertension. Well, we need to follow up such patients and see what is happening to them. Remember the definition we started with, persistent elevation. So, something scares you now and blood pressure goes up a little bit, but I need that blood pressure to be persistently elevated at least 3 times, 3 readings before, I can say you're really hypertensive. So I'm looking for evidence of secondary hypertension. As you and I know, most of what we deal with will be, a primary hypertension, about 95%, but what of that 5% that will be secondary, that maybe you and I can effect a cure because something else is going on underneath that we can take care of or get rid of? Then risk factors and comorbidities. So the medical history is very important. You're asking for duration and levels, symptoms of organ damage. Remember, the patient may not have any symptoms related to hypertension, but because we know that the blood pressure, the increased, perfusion pressure that is going on with those high elevated blood pressures, and all the alteration in the auto-regulation patterns of different organs in the system. So the brain is at risk, the eyes, the heart, the kidneys, and the peripheral arteries. So I need to get a bit of a hang as to what is happening there. Indications for secondary hypertension, renal disease, endocrinopathies, drugs that patients have taken. That these days, a lot of, with all the issues with COVID, even before COVID, and all the societal stressors, a lot of people are going, taking recreational drugs, that cause intense sympathetic activation and vasoconstriction. Then what of the risk factors? Is there family history, hypertension, diabetes, previous antihypertensive? So those are the kind of things you want to get in your history. And then of course in examination, I'm confirming this blood pressure elevation, I'm checking the BMI, waist circumference, and signs of organ damage, and stigmata of secondary hypertension. So this is from the ESC, ESH guidelines. So, you're a male, your age, you're smoking, you have dyslipidemia, you have whether you have impaired fasting glucose or you have diabetes, you're obese, family history, the asymptomatic organ damage, pulse pressure, electrocardiographic evidence of LVH, even if the man doesn't have any symptoms at all, echocardiographic evidence of LV mass, LVH, so we have the cutoff values for the LV mass, carotid wall thickening, carotid femoral pulse, pulse wave velocity, ankle brachial index, CK, EGFR, and presence or absence of microalbuminuria, and then diabetes mellitus, like I said, is it patient diabetic or the patient has impaired fasting glucose or impaired glucose tolerance. Remember that the patient who has impaired glucose tolerance has as much, problems, as when you come to risk profile as a patient who is outrightly diabetic. And then we look for established CVD. Has a person has a stroke or TIAs? Has a person had an MI before? Because maybe that might, if for those of us who practice on this continent, this might be the first point of diagnosis. Somebody has had a stroke and then the blood pressure is very high. That's the diagnosis of the hypertension, and then we work backwards, heart failure, CKD, and the rest. And then evaluation continues. So looking at the investigations, the aim of the investigation, you're looking for evidence of added risk. You're searching for secondary hypertension, presence or absence of target organ damage. And these are, gamut of things that, the guidelines ask us to do. So you're looking at the hemoglobin, which tells you whether this patient already has some kidney CKD going on, what's the fasting plasma glucose, what's the cholesterol level, the triglycerides, the urea electrolyte and creatinine, the uric acid, urinalysis for protein, and a 12-lead ECG. Of course, depending on what you find from the history and from physical examination, you can now go to extended, investigations to rule out other things like HbA1c, Holter monitoring, carotid ultrasound, pulse wave velocity. Okay, so we are doing all this because we know that more than 80% of our patients, of hypertensive patients, have additional comorbidities. And more than 50% of them would have 2 or more comorbidities by the time you diagnose them. So all those things we are doing is so that we can re-stratify these patients. The numbers don't answer all the questions. So this is a chart from the ESC guidelines. So we look at the numbers, talking about high normal, grade 1, grade 2, and grade 3 hypertension. But then, what else does this patient bring on board? What else is this patient bringing on board? Is this patient just elevated blood pressure? Nothing else? Or do they have 1 or 2 more risk factors, or 3 risk factors? Or they already have evidence of hypertension-mediated organ damage, or CKD, or diabetes? Or the patient already has an established CVD? The ESC adds another layer of classification, staging the disease. So when there are only risk factors and it doesn't matter the blood pressure, so the person could be high risk, okay, but still uncomplicated. But then by stage 2, we are talking about asymptomatic, a disease, and by stage 3, we have symptomatic disease. But see what happens, So this patient who is 130 over 139, which you and I will say, not you and I, the ESH will say is high normal. May be at same risk level as somebody who comes into your clinic with a blood pressure of 179 over 109. Okay, but because of the number of risk factors he has, for instance, if you look at this particular box, so 179 over 109, but has 1 or 2 risk factors, so he's moderate to high risk. But the person who is actually high normal, but already has evidence of target organ hypertension-mediated organ damage, may also be at the same moderate to high risk. So this just supports the point that the numbers don't answer all the questions, alone. And we're going to, we're looking much deeper, which is why we're spending time evaluating this patient. So that brings me to the point that early detection is crucial. And why am I saying that? I said hypertension is majorly asymptomatic. And when symptoms are seen, usually symptoms of hypertension-mediated organ damage. So that my patient who comes into clinic and is hypertensive and is already having shortness of breath on exertion. Okay, so I'm thinking of LV dysfunction. But I don't want him to get there before I put him on a course of therapy. And early detection may lead to early treatment and control. I say may because sometimes we detect it and the patients don't want to, take treatment, or they feel they're too young, or some, for whatever reason, they don't want to take medications. And we know, I've shown you clearly, from studies that BP control actually reduces complications. And strategies that we use for early detection include mass screening. You and I know that ISH a few years ago had started this May measurement month, where we just screen everybody, whether you don't have hypertensive or you haven't even had your blood pressure taken before, and all that. And the one we did in 2017 in Nigeria, we picked up quite a few. And then regular BP checks. What I tell my patients is any contact with a healthcare provider, please stick out your arm and ask them to check your blood pressure. You take your child to the hospital for immunization. While they're doing the vitals, just stick out your arm. It doesn't cost anything. You go to the pharmacy to refill your prescription for, let's say, an upper respiratory tract infection. Just get your blood pressure checked. At least it also helps us, because when I'm evaluating you, I can say, okay, as of 6 months ago, as of 3 months ago, he had a normal blood pressure. So whatever has happened must have happened within the past 6 months or within the past 3 months. But despite the significance of the condition we are dealing with, hypertension is still difficult to treat. 30% still unaware of the population will still be unaware of that they are hypertensive. About 40% of the hypertensive are not on treatment, and even if they are not. There's lack of control. Hypertension control around the world, is about 30%, or some of the developed countries have notched it up to about 40 and all that, but less than 10% in developing world. And this is the problem. We have the burden of high blood pressure. We have very low control rates, and we don't have the facilities, to look after these patients when they happen. Okay, and what's in those with a very high CV risk factors. And we know that a lot of patients will require more than 2 drugs for treatment. I just put this slide here, this bar chart here, because this, and this upsets me a bit, because since med school, this is all I've been hearing, the rule of thirds, 1/3 untreated, a third of the treated uncontrolled, and only 35% treated are controlled, and it's still happening, because a few years ago, in 2013, the cardiology units in Louth, went out during the World Heart Day, and just went into the local market near us, and we checked their blood pressure and checked all the other things, the risk factors, and this is and the rule of thirds was still there. A third still had elevated blood pressure, more than two-thirds, about 2/3 didn't even know they were hypertensive. And then for the known ones who were on treatment, only about 1/3 were controlled. And this is how many years down the line, 2013. This is how many years, from the time, that observation was made. So it means that we're not winning the battle yet. There's still a lot more work for us, to do. And to buttress up, this is a review that came out of Nigeria, led by Dr. Oga, and what they found was that, reviewing a lot of the studies, awareness was 14 to 30%, treatment less than 20%, and control 9%, which is not a good score at all for you and I who are looking after this hypertensive patients. So how can we do better? So what are the treatment strategies? Are we doing monotherapy or multiple medications, or are we doing the single pill combination? These are issues we need to consider because we're trying to improve care, we're trying to improve control, we're also trying to improve awareness. So if this just shows us that a lot of our patients will need multiple medications to get them to target. So these landmark hypertension trials from Accomplish to All Heart to ASCOT BPLA, UKPDS, IDNT, ABCD, all of them. So if you look, most of the patients needed more than at least 2 medications to get them to target. So when we start hunkering around or we're hogging the monotherapy because the patient doesn't want to feel, his own issues are a bit too complicated, and that's why he needs 2 or 3 medications. Please bear this in mind, that even if you try, to do that, except the very, very low blood pressures, but you need to keep an eye because over, a few years, a lot of people will need much more than 1 medication to control the blood pressure. And that is also comes from the point that pathophysiology of hypertension is also heterogeneous. I find that no single drug mechanism of action will be sufficient to control, blood pressure in most people. For instance, you give a patient, the 2 important hormonal systems, the autonomic system and the renin-angiotensin-aldosterone system. Okay, and then you give a patient diuretic and shrinks the intravascular volume. You activate that other, the RAS system, and that kind of counter, balances whatever reduction you have had with your diuretic. So a lot of patients will need, 2 medications coming from different sides. And there are a lot of advantages of using combination therapy. Makes a convenient dosing format. You can use lower doses and not hit, the maximum dose of one particular medication, and that would, you can give them once a day. You don't, you have additive or synergistic antihypertensive effect at lower doses of the individual components, and the drugs in combination can counteract the side effects of each other. For instance, combination of a calcium channel blocker with a RAS blockade reduces the ankle edema we have with calcium channel blockers. And of course, you have early normalization of the blood pressure. Please remember that the patients don't have symptoms. So everybody's looking at the the BP readings, and the person comes, 1 month, 2 months, 3 months, 4 months down the line, and the blood pressure control is not there, and we haven't achieved control yet, and then patients kind of get disillusioned. Maybe this is not what it is. Drugs are not working and all that, because you and I are trying to be nice, to give low doses and to give just one therapy, one medication instead of doing multiple medication. So yes, we're saying combination therapy, but this is what ESC advises us to do. Please be careful what you combine. Okay, so the green lines are, go. Okay, those, the winners any day, whether thiazides with the RAS blockers, thiazides with the calcium channel blockers, or thiazides with with ARBs or ACE inhibitors. Okay, we can do ARBs and calcium channel blockers, but please don't do ARB and ACE inhibitors. It's a red line. Yes, you can get a little bit more blood pressure control, but the adverse effect is actually, worse than what you want to do. The dashed green lines, yes, you may use it for obvious reasons, so they're useful combination. The black ones, dashed lines, are possible combination, but the red one is please don't even go there. Okay, and that was borne out in the recommendation for treatment by the ESC guidelines. Okay, talking about the initial therapy, dual combination. So whether you want to do ACE or ARB plus or a calcium channel blocker or a diuretic, but the only consideration for monotherapy is when the grade 1 hypertension blood pressure is historic less than 150 millimeters of mercury, and in patients older than 80 years or frail patients, because you don't want to push them too hard. You don't want to lower the blood pressure that much. Even when you go to step 2, you are doing triple medications. Okay, and so you ACE, ARB, CCB or plus a diuretic. But what's been encouraged is a single pill combination where, yes, I'm giving you 3 medications, but everything is in 1 pill. Even when we go to, resistant hypertension, everybody trying to reduce, this patient's pill burden. So even when you're dealing with peculiar situations like patients who have coronary artery disease, the same kind of combination that we are doing, ACE, ARB, a dual combination plus beta blockers or CCB, diuretics or beta blockers and, plus diuretics. But usually they will need more than 1 medication to get them to, to target. And then triple combination, like what we have said earlier on. You're dealing with patients with chronic kidney disease. So everybody seems to be on the same, kind of pathway, trying to get these patients to target. And like I said earlier on, we talked about synergistic action. So your calcium channel blocker will cause arterial dilatation, arterial peripheral edema, effective in low renin patients. That's why, Black patients, tend to respond a lot to CCBs and reduces cardiac ischemia. Okay. But then when but it doesn't cause a venodilatation, and that is why they have that the ankle edema. But when you add a RAS blockade, you do a venodilatation, you attenuate the peripheral edema, it's effective in high renin, and also no effect on cardiac ischemia. So you try to balance things out. I give you this one. Yes, it reduces the blood pressure, but sets up a counter-regulatory mechanism which the other medication can take care of. So the thing is that many factors can impact adherence in hypertension management. Because yes, we've been talking about this single pill combination, we're talking about the good things patient can take, but except the patient swallows, the good drug, it won't work. So the things that affect our management, yes, we're talking about control. We want to get the patients to target. We want to make sure we reduce morbidity and mortality. Okay, we want to make sure that quality of life is also good. So a lot of factors. There are patient-related factors like adherence. They don't want to take the medication. You have social and economic related factors. A lot of the medications are not cheap. And then you find some of these patients, when you have a hypertensive patient who has dyslipidemia, who has, let's even just say hypertension and dyslipidemia, then I put the patient on 2 or 3 medications to control the blood pressure, then I put on a statin, and maybe this person is an artisan, who earns a subsistence living, or the lowest cadre in the civil service. You find that it takes a real chunk out of the, their income. And because there are no symptoms, so they don't see the urgency of trying to get these medications to control the blood pressure. Sometimes it's health systems, healthcare, team related factors. Health systems, the man has to travel miles or to get the blood pressure checked. At the point they give up, because they travel 4 or 5 miles, to get to you, and all you do is wrap your cough around, their arms, and then repeat the same medication. But I mean, the day those medications are no longer working or something else pops up, you probably wouldn't know because they stop coming. A lot of them, cost of care studies have done in Africa have been shown that a lot is spent on transportation, to healthcare facilities, because where they're getting this, real help is actually very far from where they live. And then sometimes it's the care team, we don't talk to the patient, our communication is very poor. We talk down our patient, they don't understand what we're saying, they don't even understand where we're coming from, and we want them to adhere to therapy. It could be therapy related factors, all the side effects that are going on. A lot of the antihypertensive medications will cause a bit of erectile dysfunction for patients, and some men can't tolerate that. And then when you have such issues, then adherence becomes a bit of a problem. So to address all this, we need a multifaceted approach, if we're going to improve adherence, because we can't be talking about control, we can't be talking about reduction of mortality and morbidity if the patients are not adhering to medications, they're not adhering to plans, they're not swallowing these medications. So patient education is very important. Okay, it's not just on the hypertension, the disease itself, on the modality, treatment modalities, long-term complications. They need to understand, what we're talking about. We need to bring them on board. Remember that they're the most important person in this team that we have formed. And then, of course, patient engagement, building on the foundation of education. Sometimes we feel, they don't know much, so there's really no point to engage them, but that has been shown to be false. Various interventions, that have tested patient engagement have found that educational sessions, health coaching, motivational interviewing, would all lead to, the stage of change in behavioral, counseling. And of course, the impact of the pharmacist on hypertension management, that we cannot ignore or can't run away from. Remember, we're talking about, community involvement and control. So poor adherence is a major cause of poor control. Whether sometimes it's pill burden, increased number of pills, and what studies have shown is that the higher the number of pills, the higher the frequency of non-adherence. And then side effects, communication, we talked about cost and competing needs. But we must note that non-adherence is expensive. This study looked at the cost of non-adherence and find that, 200,000 lives will be saved in 5 years if you increase adherence by 80%. Okay, non-adherence associated with increased risk of coronary heart disease, cerebrovascular disease, heart failure, and deaths. Okay, and then when they don't adhere, they are the ones that are using emergency room services, they're getting hospitalized and staying longer in hospital. And consequently, that pushes up the healthcare costs. So for the healthcare, our healthcare system, they want to make the policy. It actually costs us a lot more, to look after these patients when they have developed issues and make things easier for them to take the medications at the beginning of the ladder. Healthcare providers, I talked about them, contribute a lot to inadequate control in hypertension, either because of inertia or poor communication skills, or inadequate knowledge and skill sets. And that's why, all the seminars and webinars, you learn, things change every day. We get new evidence, so we keep coming. I keep learning every day because what you know today may be obsolete by tomorrow. Okay, so this is a study that looked at therapeutic inertia, as an impediment to achieving the Healthy People 2010 blood pressure control goals. And what they found was that about 87% of clinic visits, had BP uncontrolled greater than 140/90, and the patient usually don't like escalation of medication dose. Oh, I just had a fight with the bus driver. Oh, I just I didn't sleep well last night because I was thinking about this consultation. Oh, any reason to explain away the increased office blood pressure. And then when the inertia is seen on the side of okay, we'll see you next visit. And next visit, the story continues. So what can we do to improve compliance and control, or adherence and control? Effective communication with the patients, okay, and the use of single pill combinations to reduce pill burden. I just put this cartoon there. We must communicate effectively with the patients. Okay, so this is the hypertensive patient. They need to understand the disease, the risk, the adherence, and benefits of adherence. So this man who is hypertensive has been asked to walk the dog. Of course, he's having a conversation with his doctor. Of course, I walk the dog every day. He walks the dog, but the essence of walking the dog is lost because the essence of walking the dog is that so he too can walk and get some exercise and get his body moving. But the guy is driving along and the poor dog, has to run after the car. So single pill combinations are valuable assets in this battle. They reduce the pill burden, they increase achievement of target BP, they reduce side effects. Remember, I told you earlier on that when I'm using all this single pill combination, then our combination therapy, then I can use smaller doses without hitting the target doses and really bringing on the side effects. It improves adherence. If a patient needs to pop only one pill, they are happier and more likely to adhere and reduces costs. And studies, these are things, so simplicity of treatment, compliance, efficacy, tolerability, price, and flexibility. And there's, a lot of studies have also shown us the impact of pill burden. Okay, this, on the left, So in hypertensive treatment adherence, and then on the right, you see persistence with antihypertensive therapy regimens. Okay, so this is, on this right, you have, the level of adherence depending on the number of medications you have. So adherent to full treatment, by the time you see the patients are written all that 3 or 4 drugs, and then adherence to one drug. So what they found that like up to 4 years down the line, more of the patients, up to 98%, were doing only one medication. You had only less than 55% doing, your full treatment. And then when you come to persistence, so whether I'm using multiple therapy now, but whether I'm using it as single pill or free combination, this study shows that if you use it as a single pill combination, the degree of adherence is actually much better. These are 5 different studies, everybody demonstrating the same thing. So the other thing we can do, remember we're talking about, improving care, improving awareness, improving treatment, improving control, and moving it, to the community level. So how do we improve? We need to improve access to healthcare and medicines, and this would also improve adherence. So we need to equip the primary health care centers to screen and monitor treatment for CVD and risk factors. It's too much of a burden for that hypertensive patient to travel how many miles, to see me at the, teaching hospital every 2 months or every 3 months, just to check the blood pressure. And if I have a very adherent patient, all those visits, blood pressure is normal. They can get this. So if we equip the primary health care centers with good, functional speeds and things with, urinalysis kits and all that, they can check the blood pressure there, fill in their prescription, and maybe come to see me twice in a year just to make sure, everything is in order. And if I need to change medications, I can change medications and then go back, to continue their monitoring very close to them. So it doesn't interfere with their social lives, it doesn't interfere with their work life, and it doesn't cost them, doesn't put a hole in their pockets just to have, their blood pressure checked. Community pharmacist involvement. This has, we can't run away from this. This has helped a lot. And they find that, for the very good community pharmacists, the patients like to talk to them, they like to have a conversation with them so they can help, and if they have a monitoring, if they have sticks around, whenever the patient comes in, if he comes in for something else, to fill in their prescription for upper respiratory tract infection, they can feel, they can check their blood pressures, and the pharmacist can, from time to time, how are you doing your medications, making sure that they are, adhering to plan. And engaging the CHU, this is the community health extension workers. Yes, they are not medically, they are not medically qualified people, but we can train them. And now with electronic feeds and all that, they can record. And with SOPs, they know what are red flags. They know when to push patients on what things to look out for that will say, I don't think we can continue monitoring at this level. I think you need to go see them at the big hospital and then come back and we'll continue. And the use of community points of socialization. Where do the patients want to go? Where do they like to go? Where do they congregate? Is it the churches? Is it the mosque? Is it the prayer? Whatever it is, let's follow them there, to screen them, to find out what is going on, just to make sure we're getting a hang on the control of the hypertension. And in the next few slides, I'll just show you evidence that this works. This is a meta-analysis, reviewing a pharmacist intervention to enhance blood pressure control and adherence, and then this was what they found. They looked at 15 studies, testing 16 different interventions, with data on over 3,000 enrolled patients. And the conclusion of the study is that pharmacist intervention can significantly improve medication adherence, systolic blood pressure, diastolic blood pressure, and BP control in patients with essential hypertension. Remember, we are carving out the essential hypertensive patients because the secondary hypertensive patients need a lot more than just their blood pressure control. And 8 of the studies of these 15 that were reviewed actually showed significant reduction in blood pressure, p-values less than 0.001, systolic and diastolic, and then even the difference from baseline to endpoint was also quite significant. So we can't ignore, what the community pharmacist can bring on board, to help us control hypertension. So this is a very interesting paper. In fact, I was at the meeting where it was presented, and everybody was like, seriously, what is going on? I had talked about where do they socialize. So this looked at effectiveness of a BABA-based intervention for improving hypertension control in Black men. This was study carried out in Dallas in America, and we know that if you've watched all those films, or if you've lived there in abroad, you know that for those communities, the barber shop seems to be a congregation point, a socialization point. People are going in and out of the place. So they trained the barbers, on how to check blood pressure, how to give advice, how to give counsel, how to monitor, either diagnose or make sure patient is on target. And it was very interesting. So 8 shops, with 77 hypertensive received the standard BP pamphlets. Nobody did much of an intervention. But for the interventional groups, which consisted of 9 barber shops with 75 hypertensive, so the barbers continually offered BP checks with haircuts and promoted physician follow-up with gender-specific pair-based health messaging. And this went on for 10 months. And the conclusion of the study was that the effect of BP screening on hypertension control among Black male barbershop patrons, was improved when barbers were enabled to become health educators, monitor BP, and promote physical referral. Remember, we're talking about moving control, moving care, to the community. So the man goes to have a haircut, has a blood pressure check, has some medical education, has some pamphlets, has all sorts of promotional activities. Excuse me. I'm sorry. Promotional activities, go on while he's getting haircut and socializing with friends and having a good time. So it doesn't feel like a bother. It doesn't take a lot. It doesn't take much out of his routine, out of his daily life. And then they actually found that there was absolute group difference of 8.8%, which was quite significant, even after adjustment for covariates. So this thing works. The barber shop may not be relevant to us in Africa, but depending on the community where you are, the country where you are, the city where you are, we know where they congregate, where they go to socialize. So we can take the control to them there and not just wait for them to come to us. So in conclusion, what I've been saying to you in the last 45 minutes, that hypertension remains the most important CVD risk factor, and prevalence continues to rise, especially in low and middle income countries. That awareness, treatment, and control is still suboptimal. Despite all the knowledge, all the drugs we have in our armamentarium, we have about how many classes? Up to 6, 7 classes, starting from diuretics, calcium channel blockers, ACE inhibitors, RAS blockers, ACE inhibitors, ARBs, alpha, central blockers, beta blockers, the whole gamut. Yet we don't seem to have a hang on the control. And what are the reasons affecting control? Adherence. Those drugs will not work except our patients are convinced enough to take them, to swallow them. So the factors that affect adherence, range from patient-related issues, the pill burden, the quality of life, they don't just, feel like taking the medication. Some feel they are too young to have hypertension. Healthcare providers, what are we saying to them? Are we talking to them? The socioeconomic issues, the man is so poor, why should I spend money to buy pills that I can't feel it's doing much for me? If I have a headache and I buy paracetamol, then of course my headache goes away, and there's benefit for spending money on paracetamol. But I spend money on hypertension, so the risk, the problem you and I are trying to prevent is not an immediate thing. It's going to happen years from now, and the patient doesn't see that except we sit down and take time to explain those things to them. Systemic and medication issues. Don't forget the side effects of the medications, and then our healthcare system. All those things contribute to hampering our treatment of hypertension. But we have strategies we can use to improve control, and there's evidence that they work. Okay, regular screening and awareness program. The name Measurement Month has started, so we take advantage of that. Is it church programs? The women have a meeting, the men have a meeting, everybody, some social something. You can, check their blood pressure and see what, it's going on, at least we can get those who didn't know they were hypertensive, those who are on medications and think they are controlled and not controlled. So that would help us, move us up a bit, and move us up a notch or two on the ladder of control. Use of single pill combination to reduce the pill burden for this patient. Patient education and counseling. It is very important, because if they don't understand what you're saying and you can't get them on board, they will not take those medications. I talked about task shifting and task sharing. Okay, those of us in the teaching hospitals and big centers, we can't, with that burden of 30-something% being hypertensive. That's some if you look at that paper, in some of the regions, it's almost 50%. How can one, say, and those regions probably would have one or two big teaching hospitals. They can't handle the burden. Okay, so we need the community pharmacists on board. We need the CHUs, okay, and then we can take it down to the socialization hubs. And I believe that will help us to control. Thank you so much for listening to me.
Thank you so much, ma'am, for such a wonderful presentation. I must say that it is very comprehensively packaged presentation. In just 55 minutes. You have started from definition of hypertension. You have covered all major guidelines, the recommendations, starting from different blood pressure values till management. But I have personally liked this community-based approaches, particularly involvement of pharmacists, CHIUs, or very interestingly, the example which you have given, one example from USA, that is involvement of some trusted community partners like barber shop. That is really fantastic, and something which can be uh, you know uh, used in our region as well.
Sure.
Now I will take up some questions, ma'am, on behalf of audience, and request you to kind of respond to them.
Okay.
Well, going ahead now, the first question is related to which are the factors primary care physician should consider in primary care setup for measurement of blood pressure, and which device should be preferred, automatic or manual?
Okay. If I understand the question, factors to be considered in measurement of blood pressure. Like I said, any contact you have with any patient, any adult patient, please check the blood pressure. Because we know that the ravages of elevated blood pressure or hypertension is actually worse in the African and the African American. And studies have shown that for every degree, yes, I show you the controls and the reductions, that 20 millimeters systolic and 10 millimeters diastolic elevation would actually double your risk, or can reduce it depending on whichever way you're going. But we find that the effect is actually worse in the African or the African American or people of African descent. So what's been shown is that even when the complications happen, they tend to happen at a much younger age in the Africans. If you look at things like studies on strokes and heart failures coming out from Africa, the mean age is the early 50s, 51, 52. But when you look at the same disease entities from the developed world, those are diseases of the elderly. Their mean ages will be 65, 70. Okay, so the ravages of hypertension is very real for us. I told you about the minority report that was written after the JNC 7, and the person who led that report, Professor Gedegbe, he is of Nigerian descent, and the argument was that the people who will bear the brunt of this, shifting to an upper level will be the Black person. We're going to lose all the benefits we have gained over the years. So please, once you have contact, they come in for a fever, check their blood pressure. They come in for an upper respiratory tract infection, check their blood pressure. It doesn't cost you anything. And when we evaluate patients, we find that it's actually, for men, we don't have much of a history. But for women who have had children, at least we can say, okay, during your last pregnancy, when you had antenatal care, your blood pressure was normal. But for the men who haven't been, the men, Dr. Raul, you guys are strong people, you are never ill, everything. So you can find a man who hasn't been to the hospital, who hasn't checked blood pressure for over 20 years, so where do you start? Okay. Then the argument about figs and all that. Yes, we tend to hog our mercury sphygmo manometer. But if you get a good electronics fig, we've seen that the levels they're about the same. Okay, but the things that there's so many brands in the market, and some on the wrist, some on the finger, and all that. So get an arm, the big ones, the arm ones. They're very standardized makers you can get from. If the WHO has a website where you can find standardized equipment, and then from time to time you need to standardize the equipment against the mercury. So remember that mercury is a poisonous metal, and UN is pushing to kind of phase it out of regular environmental use.
Okay. And ma'am, then if any patient, maybe any adult patient has
Yes.
high blood pressure, and who comes maybe for random visit or maybe for any regular checkup or having any other acute issues like maybe infection, as you said, respiratory tract infection. In such case, then it is recommended that blood pressure should be measured next time, right? And even if
Yes.
it comes high for second reading, then how many such reading for what duration is recommended to declare him or her as a hypertensive patient?
Okay, thank you. That's a very interesting question. The guideline says 3 measurements, at least 4 weeks apart. But there's a proviso, and that is why, if you remember, if you follow the lecture, I spent a lot of time on evaluation. So I've evaluated you. All I've seen is this notch in your blood pressure. Your cardiovascular system is fine. Nothing happening in your brain. Nothing happening in your kidneys. Nothing happening in your arteries. And then the blood pressure is not 200 over 120. Then I can, let's say it's 150/95. Then I can say, okay, go home. I'll see you come back in a month's time. Let me cross check the blood pressure. But please, as I'm sending that patient home, he can start the non-pharmacological management. So I need to get into his social life. How much salt does he consume? If he's obese, this is the time to start losing weight. This is the time to start exercising. This is the time to start eating right. This is the time to step down on the alcohol, the cigarettes, and all that. So it's not that I send him away and then nothing is happening. So he's doing all the lifestyle modification. And you know that if we do the lifestyle modification, we have data from the DASH diet that you can shave off at least 20 millimeters systolic, and up to 10 millimeters diastolic, by reducing salt, by losing weight, by exercising, by eating a lot more vegetables and fruits and cutting down on the carbohydrates. Okay, and then I check it again and again. But I have a patient who is sitting in front of me, who is already breathless on climbing the stairs, or who is having chest pain and having palpitations. Remember the chart I showed you from the ESC? I'm not going to send that patient home and say, come back after 3 weeks, because there's evidence of hypertension-mediated organ damage. So treatment starts immediately. Okay, so proper evaluation will help you decipher who goes away for me to do the guidelines of 3 measurements and then confirm your hypertension status, or start you to start the treatment immediately. Sometimes my students sitting in the consulting room with me are wondering what I'm doing. Somebody comes in with a 150, 90, and I'm sending, okay, do your kidney function test, your lipid, your sugar, do all this. And somebody comes in with 140 over 90, and I'm writing like 3 or 4 medications, and then it doesn't make sense, to them. But because I've evaluated this patient, so this patient with 140/90 maybe already has left ventricular dysfunction on echo, has LVH, ECG showing me SCT wave abnormalities and all that. So this patient needs not just blood pressure control, but something that would help, cause reverse remodeling. So that is how, what affect, whether I send you back or start treatment immediately and all that.
Okay. And so, ma'am, if there are persistently bleeding is high, you already have mentioned that if it is high, maybe second, third time, he or she should be instructed for some lifestyle approaches. Then, ma'am, what is the right? I mean, as per your recommendation, what would be the right blood pressure from where antihypertensive medicines are generally prescribed?
Like I said, the right blood pressure also depends on what else you're bringing on board. Okay, so do you have other risk factors? Do you have target organ damage? So if you have target organ damage, even at 140/90, I'm starting you on treatment. Okay, but you don't have any evidence, then I'm investigating you for asymptomatic organ damage, because some may have proteinuria, but nothing is showing. Some may have abnormalities in their, renal function. Okay, so, and that would also affect the choice of medication. So not just when you start treatment, what you bring on board, okay, but knowing that a lot of my patients will need at least two medications to get them to target. Diuretics, very important for us in sub-Saharan Africa, because we tend to run a volume overloaded hypertension, low on renin. So, diuretics, tend to help all the other antihypertensives that we use.
Okay. And ma'am, once any target blood pressure is achieved, then can someone have uh, pills break? If yes, then will it be a temporary or permanent break?
Usually, I don't advise pill breaks, because if we look at what are we calling hypertension? I mean, I hear that story in my clinic every day. Oh, my blood pressure. Are you sure it's not too low? It's now 110/60 or 110/70. My next question is, do you feel any different? When you get up, do you feel woozy like a drunk person? And I'm checking the blood pressure sitting, standing, and it's all normal. I mean, maybe when he stands, the body even kind of adjusts and it goes up to 120/80. So he stays on his medication. So we're trying to make people to be less number centric, whether on the upward journey or on the downward journey. So it's not just the blood pressure level plus symptoms. And usually I don't give them breaks, because when I have good patients who have developed the habit and taking their medication, then I can reduce the dosages or the number of pills if I feel there, but not to ask them to take a break. They take a break and they never come back, because they will just go out with a flag. They're very happy. Oh, the doctor has declared me, free of hypertension and all that. And I don't want them to, be at that point.
Right, ma'am. And moving on to next question, what would be the best and maybe more safe treatment options in case of pregnant woman having hypertension?
Okay, so the hypertension in pregnancy is a potpourri of events. It's not just one, it's not one size fits all. So hypertension in pregnancy, some pregnant females can become pregnant. So they enter the pregnancy with their hypertension. So their treatment continues. But it's just that I have to modify the medications. Okay, make sure they're not on RAS blockade, because we know with the renal agenesis that come to the RAS blockade, make sure they're not on RAS blockade. The obstetricians like nifedipine a lot, but we have the long-acting nifedipine. Sometimes we also use diuretics, but it's usually a bit of a battle between us and the obstetricians, because diuretic causes some intrauterine growth retardation because of the reduction in blood volume. Okay, so that's one point. But one of apart from nifedipine, alpha methyl dopa, it's one of the things that have been shown not to have any adverse effects on the baby. And then there are the group who would have preeclampsia. So they go into pregnancy with normal blood pressure, and by second trimester, blood pressure starts going up and they start having proteinuria. Okay, and for some of them, you find that you just need to treat during the pregnancy period, and then after pregnancy, the blood pressure comes down. But some women never go down. That will be the start of their journey, their hypertension journey. And sometimes, renal problems may show up, in pregnancy, and blood pressure would also go up. And sometimes the first time we are diagnosing hypertension is in pregnancy. So how you deal with it and what you do with them all depends on which bucket you put this patient in. Because the patient who was hypertensive before he got pregnant is a hypertensive patient. It's just that the hypertensive patient got pregnant. And the only thing I'm doing for her is to remove, the drugs that are not good for the pregnancy, for the baby. And once we're done with the pregnancy delivery, we go back on our trajectory. Okay, for the pre-eclamptic patient, we are doing the blood pressure, reduction and all the other things, the bed rest and all that. And once they deliver, a lot of them will drop their blood pressure and will not need antihypertensive. But remember, you have to follow them up, 6 weeks after, and then ask them to continue to check their blood pressure to see what happens. So it's not one size does not fit everybody.
Okay, ma'am, great. You have mentioned about nifedipine. When nifedipine is used, particularly now in men, it has been seen that it may cause erectile dysfunction in few of them.
Yeah.
So, what is generally observed treatment duration, ma'am, with nifedipine, and what could be the approach in such cases?
Okay, it's not just nifedipine, the calcium channel blockers. If you remember the early days of calcium channel blockers, people were asking the questions and we said, oh, it was safe and all that. But now we know that it causes erectile dysfunction. But that takes me back to communication. We know that of the antihypertensives, the alpha methyl dopa, is the one that, the worst of them all in erectile dysfunction. But I've had to use alpha methyl dopa because I got my patient convinced, and I'm telling them that I need to get this blood pressure head off. Once I get this blood pressure reduced to a certain point, I'm going to take you off, and off this medication and put some more lenient medications. But having said that, a patient that has having erectile dysfunction with calcium channel blockers, that's where combination therapy would help you. So I can scale down on the dose. So if I was, let's say for amlodipine, I was using 10 milligrams, I can scale down to 5 and push up my ARBs, which were shown during the trial to actually improve erectile dysfunction, a little bit. Okay, so if I scale down that one and push up the ARB, that would help. So I'm reducing the offending drug and I'm using a drug that has a bit of, an improvement. And then if you were on hydrochlorothiazide, we also know that hydrochlorothiazide causes a bit of erectile dysfunction. I can go to medications like indapamide, that a bit, less troublesome. So that when I started earlier on, I said that it's not just a game of numbers, that there's so much that goes on, underneath. When patients realize hypertension management, I just, laugh and, just say that it's obvious this person doesn't understand the nitty-gritty of what goes on. And please, it's very important, because what has happened, and when I talk about communication, the practice on the continent, in Africa, we're not very open, like the Caucasian who will step in and tell you that there's erectile dysfunction, going on. A lot of times I open the discussion. As I'm writing the medication, I can tell you, what, this can cost this. But if this happens, let me know. And remember that sometimes the guys are not too comfortable consulting me, a female, to talk about erectile, dysfunction. But if I had opened the door earlier on at the start of the meeting, so he comes back and say, oh, Prof, that thing you talked about the last time has started happening. Without calling it names, I understand what he's saying. He understands what he's telling me, and then we can, walk around, and then some there's some type. There's a type of amlodipine that they claim, the S amlodipine, that has only the S isomer, that leaves out all the other parts that are not reducing blood pressure but causing a bit more of the side effects. So I tend to juggle around just to see what makes the patient comfortable and what will make him continue to take the medication.
Right, ma'am. Dr. Nicholas has very short single liner case study for you. A patient has been on nifedipine 20 milligram once daily for over 1 year with controlled hypertension. Then suddenly blood pressure rises to hypertensive crisis. What can be the causative factors?
First of all, I hardly use the nifedipine, the plain nifedipine, because not that they don't reduce but they reduce blood pressure too fast, and they are bound to activate counter-regulatory, effects, mechanisms in the body. Remember that at the early part of calcium channel blocker, they nearly lost their chance, in the hypertensive world because of this counter-regulatory effect. You drop the blood pressure, then the autonomic nervous system, sympathetic nervous system is pushed into action, and blood pressure goes up. There's tachycardia. All those other things are going on. Usually, when I'm doing nifedipine, I do the long-acting, which is what you get. I mean, with nodipine and all the other isradipine and all of those ones, because the blood pressure reduction is a gradual thing and you don't give room for rebound hypertension. But having said that, we know that blood pressure fluctuates. Sometimes our patients lose control, and sometimes we are over controlling them. So that patient that's just gone that way, I'm going to, I need to know why. The first thing I'm going to look at is his kidneys. Because usually when they go into CKD, you find that blood pressure control is totally lost. Okay, so I'm going for once I need to make sure that patients are taking the medication. Please, that's also important. I shared this story. One of the residents who was rotating through my unit, from a renal unit came. This patient was on calcium channel blocker, ACE inhibitor, a diuretic, beta blocker, and the blood pressure at each clinic visit was never less than 180, 120. So she comes in, he comes in and said, "Oh, Prof, I need to add minoxidil, to this patient's treatment. We are not getting control at all." Went on and on and on and on. I said, "I agree with you, but we need to make sure he's even swallowing these medications." And I said to him, "Before you add minoxidil, let's admit him for a few days and administer the medications under supervision." The guy refused admission. So I said to him, "Write the minoxidil, but I can bet you the next clinic visit, this blood pressure will still be 160 over 180 over 120." Because it was obvious the man wasn't taking all the things. I mean, it's a different thing that occasionally we lose control. How can you be on 4 or 5 medications and your blood pressure does not shift one bit? And you're looking at us and it doesn't mean anything. So for that patient, I need to reevaluate. And then it's obvious that your nifedipine 20 milligrams, I shouldn't even do it. If I want to do nifedipine, I'll do nifedipine long acting. I know you can go up to 60, 30, 60 a.m., 30 a.m. That patient needs a diuretic. And I'm sure with this kind of whatever, there may be some changes in ECG and all that. And they also will need an ACE inhibitor, to bring down the blood pressure. But having said that, if you are thinking of hypertensive crisis, the blood pressure is very high, and then I don't use the long-acting calcium channel blockers because I need to bring down that blood pressure in a few days. Okay, but these other long ones will take about 2 weeks for me to reach control. Okay, so what I do will depend on what the blood pressure is and what I think is going on at that particular point in time.
Right, ma'am. Now I will take last 2 questions. Ma'am, what does high diastolic blood pressure indicates? Can it be considered as early marker for maybe younger patients?
Early marker of
high diastolic blood pressure.
okay,
What does it indicates, ma'am? Yeah.
Well, high diastolic blood pressure, you find that it also depends on the age, the age of the patient. The younger patients tend to have a higher diastolic blood pressure because their vasoconstriction or the arterial problem is more dependent on vasoconstriction from the sympathetic nervous system. So those are the kind of patients that will come in with 130, 100 or 130, 110. And sometimes we also see those high diastolic pressures in our patients who are in failure. They have they have the very short pulse pressure and very high diastolic pressure. But whether it's high diastolic, whether it's high systolic, we know that the risk is there. So let's not even get into the argument. The only argument I'll get into is what what medication would I use for this? If it's a young patient, of course I'm going to add a beta blocker to whatever I am giving that patient. But we know that for the elderly, so that the arteries are still pliable. But for the corollary is the case. You find that those elderly that would have the systolic hypertension because the arteries are stiff, they've lost all the recoil. So you have somebody who comes with 180 over 70 millimeters of mercury. Okay, so the choice of medications will be different, but each of them I need to control the blood pressure.
Yeah, so ma'am, related to this question, that like if systolic is towards normal, like around 120, and if your diastolic is going up, maybe persistently seen higher, close to 90. So, what it indicates, and this kind of pattern is seen age specific, maybe more in youngers, or there is no such age related correlation.
It's in who?
This is it such type of pattern like systolic having normal around 120,
Yes.
diastolic going up? Is it seen? Uh, is there any age related correlation for such type of presentation?
Yeah, the much younger people, much younger hypertensive, like the people in their 30s, 40s, those 40s, I mean 40s. That's where we see this kind of, but for the elderly, by the time they're hitting their 50s and going into the see both diastolic and systolic. And then by the time they become more elderly, diastolic drops and systolic continues to rise.
So, is this will it be a concern in any younger patient who is having such kind of blood pressure pattern than the one who has blood pressure higher for both systolic and diastolic?
That's what I've said. You remember we talked about increase 20 millimeters increase in systolic and or diastolic. You know, so I mean, like I said, if I hope to achieve or something I want you to take away is let's not get into those arguments. Oh, is diastolic? Oh, is systolic? Remember, the early days where it was said that, oh, the systolic didn't matter. It was just the diastolic, But now we know that whether it's systolic, whether it's diastolic, anyone that is high is a risk for that heart. So please reduce it if it's persistent and it's, you've made a diagnosis of hypertension. I remember, the general definition I said, I gave before, persistently elevated systolic and or diastolic. So the patient is having, so I can say he has isolated diastolic hypertension or isolated systolic hypertension. But please, it is hypertension and we need to treat it.
Right. And we are at last question now, which is related to this current pandemic, ma'am. How do you differentiate chest pain and breathing distress due to cardiac problem from that of COVID-19 complications to initiate speedy intervention in emergency situation?
That's a big question. We all struggle with it. I'll share something that happened to me, during last year during a call. A hypertensive patient of ours who has not been attending clinic for the past 4 years suddenly shows up in the emergency room, breathless, coughing, chest tightness, and has a bit of edema and all that. And then the triage, physician says is heart failure, and I said rule out COVID. Okay, so why this man has been well for 4 years? Yes, he has the underlying risk factors. Things have been going on. Something, yes, there may be some cardiac damage, but something is making the man to decompensate right now. So one thing to bear in mind is that the cardiovascular risk patient, it may be difficult to differentiate. Remember that the heart failure patient may be going to decompensation and is breathless and it has this chest tightness, and then this other patient may, and it may just be COVID on top of the heart failure. So what I want to say to you is high index of suspicion. Okay, take a good history, good evaluation. When in doubt, keep patients in holding area and do a COVID test. The only thing that is not working for us is the turnaround time, for the COVID test, because you don't want to be in a hurry and take that patient into the general ward and infect every other person there. And you also don't want to take a patient who doesn't have COVID just because he's breathless and has chest tightness, move the patient into a COVID area. The other thing that's been quite helpful is CT scan. A CT scan will help you, because CT scan, of the chest CT, you can, if you don't see the characteristic pattern of the COVID and all that while you're waiting for the PCR test, to turn around. But it's never really clear for straightforward. And then the same night, I had another patient who we are managing for heart failure, and now decompensates with breathlessness and all that. And then the triage things is COVID. So it's such a dilemma. And the other thing we also try to use is the oxygen saturation. Those COVID patients will desaturate so fast. Our heart failure patients, we see them every day, even when they are whatever, they don't desaturate, that fast, even without oxygen. So please, high index of suspicion, a good clinical evaluation, and precaution. My parting word is, if you have any of those breathless patients, COVID until proven otherwise. So what that does is that it makes you very vigilant, makes you quite, you observe all the universal protection, you do everything by the book because you're suspecting COVID, as opposed to letting your guards down, oh, it's just heart failure with whatever, and then 2 days after the PCR test comes out and it's COVID, and the whole unit is shut down because everybody is exposed.
Right. Thank you so much, ma'am. I would like to pass on our sincere thanks on behalf of the entire Shalina Healthcare team, as well as on behalf of our audience. And it has been, I personally have enjoyed this learning, and I'm sure our audience must have got very good learning from this particular session. I would also like to pass on thanks to our audience. Thank you so much for your continuous interest and feedback which you are providing to us. You can write us back by responding to our emails which you are getting. You can even suggest some topics which you would like to consider for future webinars. And we are also thankful to professional bodies. They are providing CPD and CME points to our audience attending this webinar. So please stay tuned to the updates from our side so that you will come to know about our future programs. Thank you so much.
Thank you for having me.